Okay, thank you, Clive. I will launch right into it. This is following up on a couple previous sessions on TB prevention and diagnostics. This is a very big topic, so I'm just going to hit the highlights. No relevant disclosures. These are our learning objectives. Hopefully, by the end of this, you'll be able to describe the general principles of TB treatment for people living with HIV. Describe the timing of antiretroviral therapy versus TB therapy for those individuals, and recognize the impact on HIV and TB treatment of drug-drug interactions between the ARVs and the anti-TB medications. So to start with the general principles, treatment of suspected TB for HIV-infected individuals really is pretty much the same as for HIV uninfected persons. So we usually start with a 4-drug combination of isoniazid, rifampin, ethambutol, and pyrazinamide. If the TB is drug susceptible, you go with a 2-month intensive phase of those 4 drugs listed above. Ethambutol can be safely discontinued when susceptibility to isoniazid and rifampin has been confirmed. And then after 2 months, you continue the isoniazid and rifamycin for an additional 4 months, as long as we're talking about uncomplicated tuberculosis. Now, if your rapid drugs sensitivity testing results indicate rifampin resistance with or without resistance to other drugs, well, then you have to shift to an initial MDR, multi-drug resistant TB regimen. I'm not going to go into those details. Directly observed therapy is recommended for all patients with HIV-related tuberculosis. And it clearly enhances treatment success, reduces treatment failure, and resistance. There is this concept known as enhanced DOT, and that involves additional support beyond just observing the treatment, case management, housing, other social supports, re-engaging with HIV care. These interventions, collectively known as enhanced DOT, are also very helpful and should be seriously considered. Daily therapy given as DOT really is recommended during both the intensive and the continuation phase of treatment. You see protocols out there that involve thrice weekly or even once weekly in the continuation phase, but they do not work as well, especially in people with HIV. And so it is recommended wherever possible to use daily, at least 5 days per week, directly observed treatment. The optimal duration of TB treatment for patients with HIV and TB is actually not clearly known. We typically treat for at least 6 months. If the sputum culture remains positive 2 months into treatment, that is extended to 9 months. For tuberculosis involving the central nervous system in people with HIV, we typically extend to at least 9 months for that. There's been some investigation of intensifying that therapy too with additional drugs or higher doses, but it's not entirely clear what impact that has. There are certain situations in which adjunctive corticosteroids should be seriously considered. These primarily are cases where the tuberculosis involves the central nervous system or the pericardium. Both of these are physically constricted spaces where the inflammation of the tuberculosis and its control can result in damaging increases in pressure. The role of the steroids, by tamping down the inflammation, reduces the problems associated with that pressure, both in the CNS and the pericardium. So we have better evidence for the use of steroids in cases of tuberculosis involving the central nervous system. We do know that it increases overall survival for these patients. There haven't been enough HIV-infected patients in these studies to statistically see an improvement in their survival, but it's believed that steroids should be used there as well. It's a little bit less clear in cases of pericarditis involving tuberculosis. Definitely adjunctive corticosteroids reduce the incidence of constrictive pericarditis in these situations, but the studies have not clearly documented a survival benefit. It's also not entirely clear what steroids should be used, what doses or how long. I've provided a couple examples of what were used in some of these trials, and these are reasonable places to start. But as with most situations where you're using steroids to tamp down inflammation, your dosing and your length of treatment and the length of the taper is often guided clinically by the patient's performance. Now, let's shift to antiretroviral therapy. So patients with HIV infection diagnosed with TB who are not yet on antiretroviral therapy should be started on antiretroviral therapy relatively soon. There was this initial thinking that given all the overlapping toxicities and drug interactions, that it might be best to treat the TB first and then start ART. We have a lot of evidence from high-quality randomized controlled trials that tells us that this is generally not a good idea. You do want to start ART treatment soon because it improves survival, first and foremost, especially in those with low baseline CD4 counts. It also decreases the risk of additional opportunistic infections, probably improves TB treatment outcomes. And although we do see higher rates of immune reconstitution inflammatory syndrome, or IRIS, at the low CD4 counts, these are not severe enough to cause early discontinuation of treatment or substantial impact on morbidity and mortality. So broadly speaking, you do want to start your ART during the TB treatment. You're going to start with TB treatment first, but then follow up with antiretroviral therapy. And specifically, that ART should be started very soon after initiating TB treatment in patients with CD4 counts less than 50. Within 2 weeks is the recommendation. Not simultaneous. You want to give them about 2 weeks to get the TB drugs on board and to look for any adverse drug reactions. But after 2 weeks, assuming they're tolerating that, that's when you want to start ART. If the patient has a CD4 count higher than 50, then you can wait a little bit longer. You can wait until 8 weeks after the patient has completed the intensive phase of 4-drug therapy, and then you can start ART. Now, while it's worth starting all these medications in a short period of time, it is challenging. There's a lot of medications with overlapping toxicity profiles and drug interactions. So enhanced adherence support is going to be necessary for many of your patients. And we talked about the enhanced DOT as well. Now, for some of our HIV-infected patients, they are already on ART. In those situations, you are going to start TB treatment immediately, and you may have to modify the antiretroviral treatment regimen in order to reduce the risk of drug interactions, overlapping toxicities, et cetera. All of this requires a very close collaboration and communication between the HIV and the TB care clinics. And it's kind of an unfortunate reality that in many places, TB care and HIV care has been somewhat siloed in different clinics, different institutions, different divisions of the ministries of health. But this is somewhere where really close collaboration is critical. And just picking up the telephone and talking with your colleagues to come up with a shared treatment plan. It's really important. Okay, the treatment regimens, the preferred co-treatment regimen for TB and someone with HIV is a rifampin-based TB therapy of the typical kind that I mentioned earlier, combined with an antiretroviral regimen of efavirenz as the anchor drug plus 2 nucleoside or nucleotide analogs. We've seen excellent outcomes associated with this combination. And while there were some initial concerns about pharmacokinetic interactions that might require increasing the dose of efavirenz, those have turned out to be unfounded, and there is really no dose adjustment necessary of efavirenz when given with rifamycin or with rifampin. Now, sometimes that's not an option due to resistance or intolerance of efavirenz. There are some alternatives, primarily involving substituting an integrase inhibitor or a boosted protease inhibitor for the efavirenz. Of the integrase inhibitors, we have a little bit of evidence around the use of raltegravir. The pharmacokinetic studies that have been done suggest that the dose of raltegravir may need to be increased from 400 to 800 milligrams twice daily. The dose of rifampin does not need to be adjusted. And if you're using rifabutin instead, you don't need to adjust anything. Dolutegravir, as everybody knows, becoming more and more popular. We're likely to see a lot more of it soon. Has not yet been studied in very many TB-infected people with HIV, but we may very well end up having to use it. And the pharmacokinetic studies suggest that you can do this. You just need to increase the dose of dolutegravir to 50 milligrams twice daily if you're giving it with rifampin. If you're giving it with rifabutin, no dose adjustment is necessary. If you're going to use a boosted protease inhibitor regimen, it's really difficult to do this with rifampin or rifampicin. Far better to go with rifabutin if you can. Rifabutin has much less severe drug-drug interactions with the protease inhibitors. So the protease inhibitor dosing doesn't have to change that much, and you don't end up with the prospect of severe toxicities from those. Now, the protease inhibitors do increase the serum concentrations of rifabutin in one of its metabolites, so you have to decrease the dose of rifabutin and be vigilant for its associated toxicities. You also have to make sure that in this situation, your patient is actually continuing the protease inhibitor therapy, because if they don't, they could end up with inadequate levels of circulating rifabutin and thereby risk the induction of rifamycin-resistant TB. Some ARVs to avoid due to drug interactions: rilpivirine, etravirine, elvitegravir, co-formulated with cobicistat. These are relatively newer drugs, but you may come across these. And then the newer version of tenofovir, called tenofovir alafenamide, should not be used with any of the rifamycins. The rifamycins affect the drug transporters used by tenofovir alafenamide. So just to summarize the highlights, the duration of TB treatment for TB-infected people with HIV is generally the same as for HIV-uninfected patients with TB, and generally involves the same tuberculosis medications. However, complex drug-drug interactions, overlapping toxicities, and the high pill burden of treating both infections simultaneously requires extra clinical diligence, adherence support, and communication between the clinicians providing therapy. For HIV-infected patients diagnosed with TB who are not on ART, the TB treatment should be started first, and ART should be started shortly thereafter, within 2 weeks if the baseline CD4 count is less than 50, and within 8 weeks in those with higher CD4 cell counts. So I'm going to go ahead and end that now and open it up to any questions.